Assalamu alaikum warahmatullahi wabarakatuh. Very good morning to all the viewers from around the world who have come online for this most awaited webinar of our series, which is been organized along with the Dubai Pediatric Club and Vitabiotics. So today we will be having the webinar on Kawasaki disease. Myself, Tawfiq Ali, country business manager of Vitabiotics. So without taking further time, I would like to invite Dr. Sohrab to take over the proceedings. Dr. Sohrab is the president of the Pediatric Club and is working as a senior pediatrician at NMC Specialty Hospital, Dubai. So Dr. Sohrab, please, if you can take over the proceedings.
Thank you very much, Mr. Tawfiq. Good morning, ladies and gentlemen. Well, on behalf of my colleagues in the organizing committee of Dubai Pediatric Club and also members of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, India, and all over the world, maybe Japan, United States. Today, we have three eminent guest speakers and panelists. In short while, I'll be introducing them. Before that, I would like to share my slides. Is it okay, Mr. Tawfiq?
Yes, doctor, please.
So once again, good morning. As I mentioned, we are having three eminent pediatrician professor in this field, which in short while I'll be introducing them to you. Well, I would like to welcome those who have not seen Dubai to come to this beautiful city. This is the view of Dubai, Sheikh Zayed Road with Burj Khalifa at night. Members of Dubai Pediatric Club, on behalf of all of them and on behalf of the organizing and executive committee of Dubai Pediatric Club, I would like to welcome all the viewers, the executive committee, Dr. Joshi, Dr. Kalpana, Dr. Ayman, Dr. Amir, Dr. Diari, Dr. Rafia, Dr. Bandari, Dr. Bushra, and Dr. Khaled. Well, today's topic is about Kawasaki disease. As I mentioned, we have three eminent panelists. Our speaker is Professor Surjit Singh, Head of Department of Pediatrics, Chief of Allergy Immunology, Advanced Pediatric Center at PGI Chandigarh. He is my teacher and mentor. The first panelist, Professor Arvind Taneja. He is the consultant pediatrician, pediatric infectious disease specialist at Rainbow Children Hospital in New Delhi. He is also one of my mentors. I learned pediatrics from him in mid-80s in Delhi. I will talk more about him. And we have also with us Professor Walid, who is a consultant pediatric infectious disease specialist at Jalila Children Hospital, Dubai. I call him the Dr. Kawasaki of Dubai. We are learning from him also here. We have two moderators today, Dr. Kalpana Sengupta, Senior Specialist Pediatrician and Head of Department of Pediatrics at NMC Specialty Hospital, Dubai. She is Secretary of the Dubai Pediatric Club, and also Dr. Amir Toleimat, Senior Specialist Pediatrician at Emirates Hospital Clinic at the Trade Center, Sheikh Zayed Road. They are moderating the session. After the completion of the talk, question and answer will be taken with panelists. Well, now, today I want to talk about Dr. Kawasaki. It's such an eminent personality. I will take a few more minutes to introduce Dr. Kawasaki and our panelists. Well, now, what makes Dr. Kawasaki so famous throughout the world? It was not his description of the disease. It was his unique personality, being humble, treating everybody like VIP when especially the meetings were in Japan. One of the vivid example and witness is Dr. Surjit Singh. Dr. Surjit Singh, our speaker, visited Japan, I think 3 times, 2008, 2010, and 2018. He personally took Dr. Surjit Singh to the Red Cross Hospital where he described his first case. He accompanied him to Mount Fuji at the age of 85 plus. Who will do this? He treated, at the age of 93, he listened on wheelchair. Before his death for 5 years, he was wheelchair ridden. He used to see the conferences from beginning till end, listen to all the speakers, discuss with them, welcome them, shake hands with them, take photo. And on the top, it is written one of his famous quotations or mantras or mottos. Please remember this. I will come to this. Dr. Kawasaki's principle was be strict to study medicine. And if he was not strict, he would have not had the disease called Kawasaki today. And be warm-hearted to care patients. I will talk more about him. Now, this is the 2018 Yokohama, the 12th International Kawasaki Disease Symposium. As you see here, Dr. Kawasaki on wheelchair, sitting and listening. Next to him is the president of the society, Dr. Kai Takahashi, a pathologist. I'll talk about him also. And as you see here, those winners of the Kawasaki, about 3 of them are from PGI, which I mentioned. This is Dr. Takahashi. Now, this group, you please remember, they are now the pioneers in the field of Kawasaki disease. Whatever guidelines, update, any information about Kawasaki comes, they are the one. I wish Dr. Sujit Singh, our speaker, also was among them. This is Dr. Kawasaki in wheelchair, 2018 at the age of 93. Next to him, if you see here, is Dr. Kato, who first described coronary artery aneurysm by angiography. Next to him is cardiologist Masato Takahashi, the past president of the Kawasaki Society and 2017 member of the American Heart Association guidelines for Kawasaki disease. Remember, she is Dr. Jane Byrne, professor of pediatric infectious disease at San Diego, president, director of the Kawasaki Disease Center at America, and she is one of the pioneers. And I think in 2008, she introduced infliximab in the treatment of the Kawasaki. Next to her, you see here, Dr. Jane Newberger from Boston Children's Hospital. She's also a cardiologist. She was also a member of American Heart Association. Also, in the guidelines, you will see on the standing position, you see here, Dr. Kai Takahashi is a president, director, and chairman of the Kawasaki Society and Research Center in America. Next is Anne Rowley. Anne Rowley is one of the pioneers, I think, with his mentor. He's Dr. Schulman. They wrote actually chapters in Nelson, and Dr. Anne Rowley was one who described connection between coronaviruses and Kawasaki, not coronavirus 2, general coronaviruses. I think this one is Dr. Ishii. Next is Dr. Brian McCrindle. He is from Toronto. He's a pediatrician, pediatric cardiologist. He's also chairman of 2017 American Heart Association and for the guidelines in 2017. And you see here is Marian Melish from the United States, Hawaii. He was the first to describe Kawasaki disease in the United States, which was published in 1976. Well, this is 2015 at the Hawaii. You see this gentleman here is Dr. Antman. Elliot Antman is the president of American Heart Association. Next to him is Dr. Newberger. They are asking Dr. Kawasaki how he described his first case. And in Japanese, he's describing.
として10年のキャリアを経た後に
So for the sake of time, I'm not going such a humble person. Now, it is interesting to know what is meaning of Tomisaku Kawasaki. Tomisaku, his parents named him Tomisaku, meaning to make a fortune, in the hope that he might bring family some luck. He not only brought family luck, he brought for the Pediatric Society of Japan luck, to the whole nation of the Japan, and for the whole the world. And the meaning of Kawasaki, it is interesting to know in Japanese, Kawasaki means river cape. It is the name is made of Kawa means river, Saki means a small peninsula. Okay, the Kawasaki city is situated in this area. Well, Dr. Kawasaki was born on 7 February 1925. That is why all Kawasaki symposia were conducted on February to celebrate his birthday also. He was the youngest of 7 children. Family has 7 children. He was interested initially to become a botanist. He was interested in plants, but his mother said, no, you have to become physician. His mother told him that she wanted one of the 7 children to become a doctor, and that was his role to become. He studied in Chiba University, graduating in 1948, and Dr. Kawasaki decided to become pediatrician because he loved children and he saw adult people, they were making a lot of complaints and children are innocent. So, and in those days, post-war in Japan, medical residency in Japan was unpaid. And so his condition, family condition also was not so good. So he took a position in Japan Red Cross Medical Center. Please note, he joined Japan Medical Red Cross Center in 1950. He was there till 1990 for 40 years. In a small hospital in suburb of Tokyo, non-teaching hospital without any facilities. Please note, without any facilities. He described 50 cases, which now world that realize what a treasure it is. I will come to that. Please note that. This is that hospital Dr. Kawasaki described his first patient and first 50 patients. That is Red Cross Children's Hospital. Well, I will tell very briefly, then I will explain. Dr. Kawasaki saw his first case in January 1961 and published 50 cases in Japanese language in 1967. He later on, by request of his teacher, in 1974, he published in English language in the Journal of Pediatrics. Well, in 1970, the first Japanese nationwide survey documented 10 autopsy cases of sudden cardiac death, which created havoc. In the United States, Kawasaki disease independently and as a new disease in early 70s was described by Dr. Mariam Melch and Dr. Rockwell Gay from University of Hawaii, which later on they published in 1976 in Pediatrics. And in 1973, 2 pathologists, Dr. Larson and Dr. Handing in Los Angeles, retrospectively diagnosed a case in 1971 who had Kawasaki disease. Well, here you see the 2 pathologists, Dr. Larson and Dr. Landing, and this is Dr. Mariam Wesh. Dr. Mariam Wesh came to 2005 and 2014 to India. Dr. Surjit Singh knows very well, and this is Dr. Hick. Well, this is the paper in 1976. Dr. Kawasaki published in the journal called Arugi. Arugi means allergy in Japanese. Journal of Allergy. Why Journal of Allergy? I will explain for you. Because that time the whole pediatric society in Japan, they refused Dr. Kawasaki's new disease. Everybody started a skepticism that this is not. He, in order not to have conflict with his colleagues in pediatrician, he published it in Journal of Allergy. And later on, in the request of his teacher, he published it in famous Journal of Pediatrics, Journal of American Academy of Pediatrics. See who are the author. Dr. Kawasaki is there, his teacher, Dr. Kosaki Okawa, Dr. Shigematsu, head of the National Survey, and Dr. Yanagawa. I will come to that. Now, about the American Academy of Pediatrics logo, it is interesting to know that this is a child with rickets. In 16th century, rickets was, dominant that time. They thought if they wrap the child and keep in sunlight, the deformities are corrected. So the logo of American Academy of Pediatrics. Well, initially, Dr. Kawasaki thought that disease is self-limiting and it has no consequences. But the pathologist, Dr. Nobuo Tanaka, in 1965, proved that discovered they have coronary artery thrombosis, and this created havoc and lot of interest throughout the world. In 1968, the pediatrician Dr. Yamamoto and colleagues published a report of 23 patients, of whom 11 had abnormalities in electrocardiogram. About Dr. Yamamoto was a visiting pediatric professor to United States in 1963. They say he described a child which later on was looking like Kawasaki disease. So Dr. Yamamoto was first to describe in the United States Kawasaki disease. And the first Japanese nationwide epidemiological survey in 1970, as I said, it was made by Dr. Shigematsu, who was the co-author with Dr. Kawasaki. And as I mentioned, in 1976, the cases from Hawaii by Dr. Melish were published in the Journal of Pediatrics. Now, it is interesting to know why Hawaii, why not other parts of the United States? It was found that more than 2/3 of the Japanese ancestor population, they were in Hawaii. So that is why this disease was mostly found in Asian Pacific, and those ancestors of the Japanese ancestors, they were from there. Now here you see, this is Dr. Tanaka, pathologist who found the thrombosis. And here you see Dr. Kushner. He's a professor of history of medicine. Here is also Dr. Bastian from the San Diego. And this is Dr. Yamamoto, and this is again Dr. Yamamoto here. I mean, we should remember pioneers and teachers. Well, they are the one who published in the Nelson also. This is Dr. Kosaki, the teacher of Dr. Kawasaki, Dr. Shigematsu, and Dr. Yanagawa. And this is the hospital where Dr. Kawasaki described these diseases. Well, about the Dr. Kato, Dr. Sujit Singh knows him very well. Pediatric cardiologist Dr. Kato, through coronary angiography, proved that these people, they have coronary aneurysm, and these are the cases which they had no clinical sign of cardiac disease. His first case was a 4-month child. I will come to that. And in 1976, two-dimensional echocardiography was introduced, management of Kawasaki disease. And interesting to know, after publication of the successful IVIG therapy of idiopathic thrombocytopenic purpura in 1981, two Japanese investigators, Dr. Furusho and Dr. Furukawa, they independently tried this high-dose IVIG treatment of Kawasaki disease. And in 1984, Dr. Furusho introduced IVIG treatment. 4 years later, in 1988, the Committee on Infectious Diseases of American Academy of Pediatrics endorsed IVIG treatment as recommended treatment. And in 1994, our speaker, Dr. Sujit Singh from PGI, introduced IVIG treatment in India for the first time. I'll come to that. Well, this you see, this is 2005, where Dr. Kawasaki, Dr. Kato, and Dr. Melish visited PGI. Here you see Professor Sharma, Professor of Medicine in late 80s and 90s. What Dr. Kato said, I performed angiography on a 4-month-old infant. Surprisingly, multiple coronary aneurysm image. Now you see here, this is what Dr. Kato writes about Dr. Kawasaki. And he says that he was my sensei. Sensei means guru. In Hindi, guru, respected teacher, or greatest respect for a teacher. He said, whenever I met Dr. Kawasaki, he said, I will find out the cause of that. But unfortunately, he could not. And it is his will. For those who are following Dr. Kawasaki to find the cause of that. For followers, this is a message. This Dr. Kato said. Well, Dr. Schulman said, before modern therapy, about 25% of children with Kawasaki disease develop heart disease. Now it is about 2 to 4%. That is a 90% reduction. And in 1979, Kawasaki disease entered Nelson textbook of pediatrics. And Dr. Rowley and Dr. Schulman, they are the one of the first to write chapters in the Nelson textbook of pediatrics. And in the United States and other developed nations, Kawasaki disease appears to have replaced the rheumatic fever, and it is the most common cause of acquired heart disease in children. That is why I think in 1986, the American Heart Association chapter on rheumatic heart disease and bacterial endocarditis changed their name and included Kawasaki disease. That is why all specialties now interested in Kawasaki. Cardiology, rheumatology, dermatology, vascular diseases, infectious disease, everything. Now they are finding what a treasure was Dr. Kawasaki, and what a treasure was his description. I will come to that. Well, these are, you're showing here Dr. Rowley and his teacher, Dr. Stefan Schulman with Dr. Kawasaki. This is in 2015, I think. What Dr. Schulman say about Dr. Kawasaki was kind and unassuming, with a great sense of humor, and was the life of the party at the gathering. Both Dr. Byrne and others also described, said he was a rock star. He was a rock star. Whenever he entered any meeting, any conference, any symposium, all cameras, people, everything focused on him. He was a real rock star. And he was so humble, listening to everybody from beginning till end, and he never refused anybody who approached him for a photo. And another thing, he was very much interested to attend the meetings, to travel, and to sing in karaoke. I will come to that. Well, this is Dr. Kawasaki showing how he has drawn one by one of the 50 cases in color, the rashes, how the rash look. He said, Dr. Kawasaki named his illness beginning acute febrile mucocutaneous lymph node syndrome. He said, I never refer to it as a Kawasaki myself, but people they called it. And he confessed that originally the name was too long. Well, now about this first case of Dr. Kawasaki, on the 5th January 1961, when the world were celebrating the new year, a young doctor, Dr. Kawasaki joined this 1950 till 1960, 10 years he was doing research on milk allergy and worm infestation. But once he presented the report to his teacher gave him 10% okay, 90% not okay. He was disappointed. Then when he saw on 5th January, this child, he was a 4 years, 3 months old boy who had presented with 2 weeks history of fever and all features of conjunctivitis, lymph node enlargement, all you know. He discussed with his colleagues, they said, no, this is the modified scarlet fever or mild Stevens-Johnson syndrome. Everybody rejected. He just closed the file, and the child recovered spontaneously. He was disclosed that diagnosis unknown. He had so much courage to write whatever he felt. He wrote diagnosis unknown. 1 year later, in February 1962, he said another patient. And he reported his first 7 cases as non-scarlet fever syndrome with discrimination in a meeting at 1962. All rejected. They said this is not a new disease. This is something mild disease like scarlet and this thing. In 1964, he gathered 22 cases. And he called it mucocutaneous ocular syndrome in an annual meeting. Again rejected. And one of the greatest Japanese professors of pediatrics at Tokyo University, he also said what you are talking about, so much skepticism was there that he rejected. He said, no, there is nothing like new disease. He was very disappointed. And these are, the first initial cases of Dr. Kawasaki, you all know. Well, after he collected 7 cases presented in a meeting, reviewer rejected his publication. And as I told you, only after he collected 50 cases of 44 pages. Dr. Jane Berger said 53 pages. I will come to that. He was published in a Japanese journal, as I said, Allergy by Allergy. And the paper, please note, the paper included hand-drawn diagram of each patient rashes, as I showed you. And it has been described one of the most beautiful examples of descriptive clinical writing. That is why after 50 years, people are hunting for this treasure and they are finding what a treasure it was. I'll come to that. Well, this is Dr. Kawasaki's initial, see the documentation, observation, and he's showing the rash in each and everything. Now, this is the hospital he described. Now, they describe he has been called part Sherlock Holmes and part Charles Dickens for his sense of mystery and vivid descriptions. Dr. Kawasaki retired in 1990 and established the Kawasaki Disease Research Center, which he led as a director till 2019, and then as honorary chairman in 2020. Dr. Kawasaki himself never referred to the disease by its name. This was given by people. Japanese are very humble. Like last time I said, Dr. Kasai, he also didn't want the disease to be named after him. He was married to fellow pediatrician Dr. Riko Kawasaki, who died in 2019. And after her death, also Dr. Kawasaki condition became also worse. And he died on 5th June 2020 of natural causes. He was 95 years. He was survived by 2 daughters and a son. Well, see, wherever Dr. Kawasaki was there, old people, they used to come and gather and take the photo. Here you see Dr. Sujit in 2005 in PGI, and all other people, you know, these are the pioneers in the field of Kawasaki. Well, Dr. Schulman said he began to collect his cases in a special file. He labeled the file in a Japanese name equivalent to Gok. He said when later on he described what is Gok, he said God only knows. And this God only knows file started to grow, and Dr. Kawasaki then called mucocutaneous lymph node syndrome. Well, as an intern in a post-war, the adult patient, as I said, they used to make a lot of noise. That is why he went to pediatric, because of this. Children were innocent. Now you see here, this is Dr. Kushner, this is Dr. But this is 2006 when they came to India. Dr. Sujit Singh is here, and with other eminent pioneers. You see, wherever he's there, he's spotted and photos taken. Recent data from Japan suggested the incidence of Kawasaki is 2003. This is the highest in 2014. Dr. Jane Bond explained in children less than 5. In other places, 5 to 15, maximum 40. Dr. Kawasaki said, as I said, I reported as an acute febrile mucocutaneous lymph node syndrome, clinical observation of 50 cases, and I published it there. Now, this part, Dr. Kawasaki was very happy, and why I say it was a treasure. After 35 years later, in 2002, Dr. James Bourne and group from the San Diego, United States, completely translated this paper from Japanese to English. And it was up on the website of Pediatric Infectious Disease Journal. And Dr. Kawasaki was very happy. It took 18 months with the help of Dr. Shike and Shimazo, 2 doctors who were working in San Diego. Well, here, this is 2020 parents symposium. This is Dr. Levin, mentor of Dr. Sujit Singh. As you see here, Dr. Neuberger and all, and there are 2 centers in the world. One is Japan, one is in the United States, Japanese Research Center. Well, over the years, now this is interesting. The person who was rejected by everybody, all pediatricians, all Pediatric Society of Japan, he received many awards, including the first Japanese Pediatric Society Prize. And he also received invitation to the Imperial Palace to discuss his work with Emperor and Empress of Japan. According to Dr. Kawasaki, this was the highest achievement of his life. And to honor him, because every 3 years, alternately, the symposium is held in America and Japan. But to honor him, this time the next International Kawasaki Disease Symposium is scheduled in Tokyo in 2021 to honor him. Well, see, his birth was 7th February, always celebrated. And this is, I'm going, well, as I said, in 1970, Dr. Kawasaki said we were able to obtain the fund from the ministry to do a survey. In this nationwide survey, they found 10 causes of death. Dr. Kawasaki said we invited those 10 pediatricians who described, who were having these patients. Out of 10, 4 had coronary artery thrombosis. And interesting to know, all pathologists, they gave diagnosis of infantile periarteritis nodosa. Now, in 1984, in United States, there was a meeting of systemic vascular syndrome. That time, middle-sized artery involvement included periarteritis nodosa, and Kawasaki disease also added to that. And according to Dr. Kawasaki, there were 3 epidemics in Japan, 79, 82, and 86. And interestingly, after publication, it said this article had great impact worldwide and reprints were quickly out of stock. Dr. Kato also said, when Dr. Kawasaki encouraged me to publish my paper in 1975, 400 reprints reported from throughout the world. This is Dr. Kawasaki in 2009 examining a patient. Well, Dr. Kawasaki always traveled with his wife, who was a pediatrician also. And interesting to know, the first paper supplied many impressive colored photographs, which were expensive in those days. Dr. Kawasaki had a hard financial time. When he was young and he hesitated to put this color photo, but his wife, see, always wife they come and help you. However, his wife persuaded him that color photos were absolutely indispensable to his article, and she paid it. She paid it, and Dr. Kawasaki was grateful for this. And now, as I said, every 3 years, Kawasaki Disease Symposium is held. This was the 11th one in Hawaii, 18th in Japan. As you see here, he has written a sign for Dr. Antman, the president. This is one of my best photos. I like 2 of the pioneers, Dr. Born and Newberger. This is 2018 at the age of 93 years. Look how he respects the people and smile. Dr. Burns said with a twinkle in his eye. Well, he was wheelchair 5 years before. He said he was wheelchair ridden, but he still used to come and listen to the doctors, shake hands with them and take photo with them. And however, 12 International Kawasaki Symposium in June 2019 was his last. I think Dr. Sujit Singh will show a video. And as I said, after death of his wife, he also deteriorated, and at last, unfortunately, he passed away. Now you see the condition at the age of 93, he comes and sits for hours and listens to everybody. Now, this is in 2009 in the United States. Dr. Jane Berg had a conference. This Dr. Kawasaki speaks English. See how humble he is. He said, my English is like a child. Listen, please.
Good morning. My English is very poor, just like a baby. So mainly I would like to speak Japanese.
So because of time, I cannot. No, they asked Dr. Kawasaki why this disease emerged in 60s. He said that was because of measles vaccine. After measles vaccine, many cases of measles disappeared, so we could see this disease. And as I said, in 2002, he was so happy that Dr. Bond translated his initial article and described it as a masterpiece of descriptive clinical writing. They say it is one of the masterpieces in contemporary medicine. That is why they are hunting for that. And I say he never wanted disease to be his system. Now, this is Dr. Jane hunting to translate the initial article of Dr. Kawasaki. What Dr. Bond said about Dr. Kawasaki, he said, Dr. Kawasaki will be remembered for his clarity of vision and his courage. I am repeating, courage to buck the tide of the academic establishment who doubted his discovery. He stood against everybody. That is why his quotation, be strict in medicine, but be warm to the patient. Well, Dr. Kawasaki said since the first survey in 1970, 200,000 cases reported. And he said, although 6,000 research papers published, still cause unknown. And this was his will for the successors to find out the cause. Now, I will tell you about the Kawasaki in India. Dr. Arvind Taneja, Professor Arvind Taneja, our panelist today. He was the first person to describe Kawasaki disease in India in Delhi in 1977. I think that time he was in New Friends Colony Hospital in Delhi. I'm proud that I learned pediatrics from him. He is, of course, 3 cases reported in India. Second case, it took 10 years later, Dr. Nitsuri from Pune in 1988, and after that 1989 by Dr. Sheshadri, MS Sheshadri. The name reminds of Meenakshi Sheshadri, the Miss India in 1981 and Bollywood actress in mid-80s. Dr. Taneja is son of great Professor P.N. Taneja. I just want the younger generation of pediatricians to know he is one of the pioneers of Indian pediatrics. He, in 1964, established with others Indian Academy of Pediatrics. He was the president of Indian Academy in 1967. He was the editor of Indian Journal of Indian Pediatrics, 70 to 72. He was professor of Irving Hospital, now Maulana Azad Medical College in 1952. He went to United States, came and he was a full professor at All India Institute of Medical Sciences. He established Department of Pediatrics and Neonatology in All India, which was followed by Professor Walia and Dr. O.P. Gai. Professor Walia, my guru mentor. I'm very proud he wrote a foreword to my book. Dr. O.P. Gai was there for 25 years when he retired in 1989, and Professor Walia from 60s to early 1930 years. We must remember our teachers. We must remember. And you know, this Dr. P.N. Taneja established pediatric neonatology in All India Institute, which was followed by Dr. I.C. Varma, Dr. Mehruban Singh, Dr. Paul, Dr. Ashok Diwaragi. He is a pioneer. Well, about Dr. Sujit Singh, he said, only 3 cases of Kawasaki disease in India were described till 1990. We encountered our first patient, as I said, in Chandigarh in 1994. IVIG was given. This was the first time in India, and it was published in Indian Pediatrics in 1996. Dr. Kawasaki, Dr. Kato, and Dr. Melish, the guests of Dr. Sujit Singh in 2015 at Chandigarh. Now, I want to mention here, Dr. Kawasaki, after his oration in Chandigarh, he got a standing ovation for minutes. PGI and India has not seen such a standing ovation for anybody. And in 1986, Dr. Takashi said, in the United States American Academy of Pediatrics plenary meeting in 1986, they invited Dr. Kawasaki. He gave a talk there. He got a standing ovation for minutes in America. Well, this is 2007, Dr. Kawasaki with Dr. Sujit Singh, other members. This is 2006, Dr. Kushner, Dr. Ba, and Dr. Sujit Singh. This is PGI 2006, as you see. This is 2014 at a meeting where Dr. Spector, Dr. Melish, Dr. Bond, all are there. Well, in Dubai, I went through the literature. I found only in 2004, the first case of Kawasaki disease was described by Dr. Jana from the Apollo Hospital, Bellhole Apollo Hospital. This is the meeting in 2014. Dr. Sujit Singh also was a speaker. Well, this is 2018, Yokohama, see in wheelchair. He's giving award to the pediatric from PGI, Dr. Jindal, Dr. Bilania, and Dr. Ankita Singh. Dr. Sujit Singh should be proud. Of course, those students should be, fellows should be proud that they study under Dr. Sujit Singh. Well, this is a beautiful photo of Dr. Ban and with Dr. Kawasaki in the Japan Research Center. I don't know what he say. It reminds me of great ghazal singer of India, Pankaj Udas said, "Na samjho ke hum pee gaye pite pite, ke thoda sa hum ji gaye pite pite." Well, see the Dr. Kawasaki, he loved meeting, he playing drum, he karaoke, he was life of everything. I wish he was alive and we could invite him to our annual gala karaoke competition. Unfortunately, he's not here. Well, again, the beautiful photos. And this is 2000. I'm thankful to Dr. Sojit Singh for providing some of these photos. Of course, Dr. Melish also, photos I had, I don't know. It has not been saved, I think. Well, this is, I think, 2018 at Yokohama. See, this is Dr. Kawasaki, his wife and 2 daughters. They are not allowing him even to take food. Wherever they spotted him, they went and took photo. Well, briefly, I want to introduce our speaker. I have sent the profiles everywhere. They don't need any introduction. As I said, Dr. Surjit Singh, the principal investigator, Indian Council of Medical Research for the advanced research in primary immunodeficiency diseases. He is vice president of Indian Rheumatology Association. He is president of Indian Society of Kawasaki Disease. He is president of Asia Pacific Society of Immunodeficiency, coordinator of Asia Pacific League Association of Rheumatology, Center for Accidents, and very long CV. And Professor Arvind Taneja is the senior most pediatrician, pediatric infectious disease and chief advisor at Rainbow Children Hospital, Delhi. Dr. Taneja completed his MBBS in 1969 and got MD in 1973 in the center where his father was established, and from renowned Maulana Azad Medical College. And he got his diploma American Board of Pediatrics and also his infectious disease fellowship from Boston. Of course, since we have the shortage of time, I'm going little faster. And Professor Walid, he is the Professor of Pediatric and Pediatric Infectious Disease at Al Jalila Children's Hospital. Dr. Walid is the Professor of Pediatrics at Michigan State University, USA, adjunct Professor of the Pediatrics at the United Arab Emirates University, and a visiting Professor of Pediatrics in Jordan, a former president of the National Arab Medical Association, Michigan chapter, United States. So this is Dr. Kawasaki, and this is, I want to say, now this is Dr. Kei Takahashi, the pathologist. He is the chairman and the director of the Kawasaki System in Japan. He said, one of my greatest awards I received from Dr. Kawasaki is Shikishi, they say. It is written there, be strict to the medicine and kind to the patient. He says it's the biggest treasure I received from Dr. Kawasaki. And he said that Dr. Kawasaki always pioneered the disease, and he wanted to find a treatment, laboratory test, or a vaccine for that, but unfortunately, he died. And I want to mention a quote from Emerson. He said, do not follow the path that may lead. Go in a state where there is no path and leave a trail. Dr. Kawasaki did this. He didn't follow the path. He went to a new path and left there a path for the others to follow. May God rest his soul in peace. Well, this is beautiful Dubai. Now, I'm sure from all over the world they are watching us, maybe from Japan. Is it daytime or nighttime? I say, Ohayo gozaimasu, konnichiwa, konbanwa, sayonara. Thank you very much. I would like to thank the viewer for listening to me. And now I would like to request Dr. Surjit Singh, my teacher, to start his talk. Thank you very much. Over to Dr. Surjit Singh. Dr. Surjit Singh, please. Mr. Tawfiq?
Yeah,
Good morning, sir. Welcome.
good morning. I'm
Sorry,
just,
I took a bit more.
no problem, no problem. Yeah, am I audible?
Yes, doctor, please proceed.
Okay. So, good morning, Dr. Sohrab. Thank you very much for inviting me for this talk. And I'm very grateful to the Dubai Pediatric Club for giving me this opportunity to share some thoughts on a disease which, as Dr. Sohrab has just described, is so very fascinating. Dr. Sohrab has been a very hardworking resident from our department, and he's been a consummate researcher, and he showed his skills in research even while he was doing his residency with us way back in the early 90s. And I think he's carried that trait wherever he has gone thereafter. So Kawasaki disease has been a fascination ever since the disease was first described by Dr. Tomisaku Kawasaki in 1967. It still remains a mystery. There are many aspects of Kawasaki disease which we don't understand at all. Kawasaki disease is a vasculitis, but it is more common than all the other vasculitides combined. Far, far more common. It is now the commonest cause of acquired heart disease in children in most of the developed countries, but it is also likely to become the commonest cause of acquired heart disease in children in many developing countries as well, and this includes India. We see far, far more cases of Kawasaki disease than we see rheumatic fever these days. We have some data on the epidemiology of Kawasaki disease from Chandigarh. And over the years, what we have seen is that the incidence of Kawasaki disease, or at least the recognition or ascertainment of Kawasaki disease, has gone up significantly over the last 20 years or so. The present incidence rates of Kawasaki disease at Chandigarh are in the range of 9 per 100,000 children below 5. These rates would be similar to the rates found in many European countries. So Kawasaki disease is not an uncommon disease. It's not a rare disease. It's there for us to pick up, diagnose, and treat. And if you miss a diagnosis of Kawasaki disease, the consequences can be disastrous. So as Dr. Sohrab said, Dr. Tomisaku published his first report of 50 cases in 1967, and this report had as many as 44 pages. The fascination about Kawasaki disease is that even after 50 years of description of the disease, there is no laboratory test. The diagnosis rests on the recognition of a temporal sequence of a constellation of clinical findings. And these clinical findings appear sequentially over a few days. And once some new findings appear, the previous ones may disappear. So if a patient has been seen by more than one doctor, the subsequent doctor may miss findings that have been documented by the previous doctor. And this we must keep in mind. These findings, they change, and there is no pathognomonic laboratory test. There have been several guidelines for diagnosis of Kawasaki disease. And whenever you have guidelines for diagnosis of any condition, it's an indication that we still don't understand the etiology of that particular disease. The first set of guidelines were given by Dr. Kawasaki himself in 1967, wherein he described what he saw and suggested some ways to diagnose these children. In 1970, the Japanese Ministry of Health gave guidelines. In 1989, we had what were known as the consensus guidelines based on the proceedings of one of the Kawasaki disease symposia. But the most well-cited guidelines were those given by the American Heart Association in 2004. And it was these guidelines which stood the test of time till the American Heart Association itself revised these guidelines in 2017. But what we must remember is that the description given by Dr. Kawasaki way back in 1967 is still valid today. The American Heart Association guidelines do not differ significantly from what Dr. Kawasaki himself had suggested. Fever for at least 5 days, but there is nothing sacrosanct about 5. You can diagnose Kawasaki disease on day 2, day 3, and you will be right. Presence of 4 of the following 5 conditions: conjunctival injection, a polymorphous rash, cervical adenopathy, mucosal changes, acral skin changes, which in the acute stage are edema and erythema of hands and feet, and in the convalescent stage, you have periungual desquamation. This edema over the dorsum of hands and feet is the most specific clinical finding of Kawasaki disease, and especially if it is one of the parents who picks up this edema. So if an observant parent picks up edema on in an infant and the child has been febrile for a few days, you should have a very low threshold for diagnosis of Kawasaki disease, because this edema over the hands and feet is not seen in any other medical condition. So in the classic cases, diagnosis is quite straightforward, and we divide it over 2 periods. The first period is from days 1 to 10, when you have the typical findings: irritability, extreme irritability, redness of the lips, a red tongue, which is the strawberry tongue, a polymorphous rash, which can be macular, erythematous, maculopapillar, but never vesicular. A vesicular rash will rule out Kawasaki disease. This is one of our first few patients who had an erythematous rash. Then you have a cervical lymphadenopathy, which is usually unilateral, usually a single node. And this can easily be confused with suppurative lymphadenitis. And notice that along with cervical lymphadenopathy, this child has red lips and cracked lips. Then you see conjunctival injection as seen in this child, but it is usually not as prominent as seen here. This is not conjunctivitis. There is no discharge. So this is just conjunctival injection. And this is a close-up of a child with conjunctival injection. It is important to note that the vessels stop short of the limbus. So there is a clear zone around the limbus. So this is a rather typical finding in Kawasaki disease. In many children, you really have to hunt for the conjunctival injection. But remember, like a vesicular rash rules out Kawasaki disease, a discharging eye will rule out Kawasaki disease. Conjunctival injection in Kawasaki disease never has a rash, never has a discharge. And this is what you see, swelling over the dorsum of hands and feet. These fingers look swollen, and this particular finding is not seen in virtually any other medical condition. In small babies, especially babies below 6 months, this may be a rather subtle finding, and one has to hunt to look for these findings. This is a child where you have the swelling over the feet. So these are the findings which we need to be very careful about, and we need to pick up these findings in the first few days for our treatment to be effective. If you miss these findings in the first few days, then the chances of coronary artery complications increase manyfold. What happens between day 10 to 20? Essentially, periungual desquamation. By periungual, we mean desquamation which starts around the nails. So this is periungual desquamation in its early stages. In small babies, this may be very, very subtle. And again, you have to hunt for it, especially in the first few days of the illness, when you're not sure of the diagnosis. Make it a point to look at this area very carefully, and maybe twice a day over the first few days. And this is what happens after a few days. But we as pediatricians have to learn to pick up Kawasaki disease before desquamation occurs. By this time, if you pick up KD, there is a risk that some of the coronary complications may have already occurred. Like any other disease, there are several caveats to the diagnosis of Kawasaki disease. So you have classic typical patients, but you also have many patients who do not read the textbook. And we have to be aware about these patients, about these caveats. Several patients with KD do not meet the diagnostic criteria. And this is what we call as incomplete KD. Now, this is not an exception. Estimates would vary from something like 33% to as high as 60, 70%. 60, 70% of your patients may not meet the diagnostic criteria for Kawasaki disease, which just goes on to show that the diagnostic criteria are not foolproof. There are still many lacunae in these diagnostic criteria. And essentially, the more experience that a given center or a given unit has, the more will be the percentage of patients with incomplete forms of KD, because you become wiser as you commit more mistakes, and then you start picking up KD even when there are fewer than the classic criteria. So this was a 4-month-old girl who presented with fever for 12 days. We became suspicious because she had received a broad antimicrobial cover over these few days. She was irritable. She had loose stools, and that took us away to begin with from a diagnosis of Kawasaki disease, because loose stools are not commonly associated with Kawasaki disease. Her lips were red, some cracks also seen, but what made the diagnosis a little obvious was the BCG site reactivation and the perianal desquamation. The perianal desquamation appears in the first few days of illness, unlike periungual desquamation, which usually appears after day 10. So this combination made us suspect Kawasaki disease. We must remember that in young infants, KD is usually incomplete. And it is in this age group that KD has the most devastating coronary sequelae. So not only do infants have more complications, infants have the additional problem of having incomplete forms of the disease. By the time we got around doing the echocardiography examination, it was too late. The baby had developed large coronary artery aneurysms. So 12 days fever, which went undiagnosed. By the time you made the diagnosis, it was already too late. So we treated her with IVIG, but whenever you have coronary sequelae, we become more aggressive. So we gave her the whole armamentarium, infliximab, prednisolone in tapering doses, oral cyclosporin, as well as aspirin. And since the child had large aneurysms, we started her on low molecular weight heparin. But when you have aneurysms as large as this, there is precious little that you will be able to do as far as normalization of the coronaries are concerned. These children will never have normal coronaries. So this is a publication from our center on Kawasaki disease in infants below 6 months. And what we realize that in this age group, you have the maximum number of complications. We even had some mortalities in this age group, mostly amongst patients who came very late with myocarditis and with large aneurysms. And we learned through better experience that when you have Kawasaki disease in young infants, you should try preemptive adjunctive therapy. In this age group, IVIG alone will not be sufficient. So when you diagnose KD in very young infants, we would tend to use IVIG along with infliximab or even cyclosporin and steroids. This was a 2-year-old boy who presented with fever for 7 days, rash, and perianal peeling. This is how he presented. Again, the diagnosis had not been made in the first few days. And this perianal peeling, one has to undress the baby and look for it because the mother is likely to miss it. But if you see perianal peeling, this in the presence of fever, this is virtually pathognomonic of Kawasaki disease. And the advantage of picking this sign is that it appears earlier than periungual peeling. This was a 1-year-old boy, fever for 7 days, extreme irritability. Along with this, when you have BCG site reactivation, there is no differential diagnosis, irrespective of the fact that the child does not fulfill the criteria for Kawasaki disease. So BCG site reactivation does not occur in any other known medical condition. So even if there is incomplete Kawasaki disease, when you see this finding, you have to learn to be very aggressive with treatment. Fever can be the only presentation of Kawasaki disease. Now, this can happen for many reasons. Number one is that there may be other signs, but they may disappear while the child is being managed elsewhere. And the treating pediatrician at that time may not notice the other so-called subtle signs. And when the fever persists, he reports to another hospital. And for that hospital, the history that you get is that the child has been febrile for, say, X number of days. So we have seen such patients as well. 5-year-old boy, fever for as many as 17 days, irritability, no other symptoms and signs, referred as a case of enteric fever. The child had received oral antimicrobials and the fever had not responded, so they reached our hospital. The fever continued and an echocardiography was done to rule out infective endocarditis. And while they were doing the echocardiography for infective endocarditis, what they found was that the child had developed large coronary aneurysms. So we carried out a dual source 128 slice CT coronary angiography on this patient, and he had giant aneurysms in all the coronary arteries. So what essentially he had was just fever for 17 days, which can easily be misdiagnosed as enteric fever. And it's quite possible that he may have had signs of Kawasaki disease, which were missed prior to the child coming to our hospital. Some patients with KD have unusual clinical presentations, and this is what we call atypical KD. For instance, KD is a peculiar vasculitis. It usually does not have renal involvement. CNS involvement is not that common. Pulmonary involvement is not that common. So when you have involvement of systems other than the usual involvement, we call it atypical Kawasaki disease. So this was a 4-year-old boy, fever for 25 days, had cough and respiratory distress, had a patch here for which the child was given ceftriaxone, cloxacillin. Fever, however, persisted. And after a few days, someone noticed periungual desquamation. So by this time, the child was noted to have thrombocytosis, very high CRP, raised ESR. We gave IVIG, the fever promptly responded. So pulmonary presentation of KD is a known type of KD. It often results in delayed diagnosis because when you have pulmonary involvement, your focus will be on the chest and you may miss some of the more subtle signs of Kawasaki disease. Incomplete KD and atypical KD are by no means milder forms of KD. In fact, the converse may well be true because in both these types, incomplete KD and atypical KD, the diagnosis will be delayed. So therefore, the chances of complications are much higher. So just because a child does not have complete KD doesn't mean that he would have benign types of KD. For any pediatrician, KD is a medical emergency, and missing a diagnosis of KD can have disastrous consequences. So this was a very young infant, 17 months old, fever for 3 weeks, excessive irritability, a generalized erythematous rash, initially thought to be measles, then thought to be a drug rash, underwent extensive investigations till some pediatrician found pus cells in the urine, and they thought that this was responsible for the fever. They thought they were dealing with urinary tract infection. So they gave broad spectrum antibiotics, intravenous antibiotics. Fever, however, persisted. When fever did not settle down, all kinds of investigations were done, but the fever continued till the patient was noted to have desquamation, periungual desquamation. By this time, it was too late. Look at these Z scores. So the child had developed giant coronary aneurysms, and the clue here was this. So whenever you have fever with pus cells in the urine, this may be the sterile pyuria of Kawasaki disease. You get pus cells in the urine in Kawasaki disease because of urethritis. So if you have fever, pus cells in the urine culture is sterile, think of Kawasaki disease, as otherwise you may land up with significant complications. And on CT coronary angiography, this child had giant coronary aneurysms. Kawasaki disease is often referred to in the context of coronary arteritis. We forget that more than coronary arteritis, Kawasaki disease is a myocarditis as well. Coronary arteritis you would see in some like 15 to 25% patients. Myocarditis occurs in almost all the patients. And this fact was first brought to light by Dr. Najib Dada from Montreal. And Dr. Najib had visited our institute in 2018 when he dwelt at length on what this myocarditis is all about. But as pediatricians, we cannot afford to forget that KD is a myocarditis first and then a coronary arteritis. So while coronary artery abnormalities develop in 15 to 20% patients, myocarditis is almost universal. And in some patients, myocarditis can be the most important clinical feature of KD. KD can at times be lurking around in the intensive care unit as Kawasaki disease shock syndrome. So as pediatricians, when you're called to the intensive care unit to look at children or infants in shock and the child is febrile. The cultures are sterile. This may not be septic shock at all. This may be the KD shock syndrome. So before we launch on to one course of antimicrobials followed by another course of antimicrobials, be on the lookout for KD shock syndrome, because in the ICU, it is not difficult to miss some of the other soft signs of Kawasaki disease, like a red lips, red tongue, or very subtle desquamation. If you miss these findings, you may land up with very serious complications. So this lesson was brought home to us when we managed this child who was in our ICU, and he was managed like septic shock, given antibiotics. Still someone picked up very subtle conjunctival injection, redness of lips, strawberry tongue, and irritability. And this child had one of the most severe types of Kawasaki disease that we ever have encountered at our institute. So he look at the pro-BNP levels, they are sky high. So this child had very severe myocarditis. He went on to develop macrophage activation syndrome. He was in shock, required all kinds of vasopressors. However, the coronaries were not dilated, although there were some soft signs like brightness of the coronaries and no distal tapering. Normal coronaries would show you distal tapering. This child had bright and ectatic coronaries, but fortunately did not develop large aneurysms. So this is the child. So as you can see, the platelets fell down because of macrophage activation syndrome. The ferritins went up. Fibrinogen was low. Look at the pro-BNP. And this child is easily the most severe patient with Kawasaki disease that we have ever managed. He required 3 doses of intravenous immunoglobulin. He required infliximab. We gave him we gave him cyclosporin followed by oral prednisolone. He required vasopressor support, but ultimately he recovered. Gradually he recovered. Macrophage activation syndrome can occur in children with Kawasaki disease, and in our experience, it occurs in approximately 1 to 2% patients of Kawasaki disease, but you can easily miss it unless you are looking for it. So the rule of thumb is that whenever a child has very severe Kawasaki disease, or a child has KD which does not respond to IVIG, or which does not respond well to IVIG, think of an oncoming macrophage activation syndrome. KD is a disease of children, especially children below 5, but it can sometimes present in adolescents and sometimes present in adults, and then it can be associated with all kinds of problems, because your adult colleagues in your hospital may not be that conversant with the presentation of KD. So if an older child or an adult were to come with KD, chances are that the diagnosis will be unduly delayed. And like KD is known to be very severe in young babies, in adults as well, the disease can be associated with a lot of coronary complications. So this was a 27 years old. She was a dental surgeon, had been running fever for many, many days. She had rashes, had a cervical lymphadenopathy. This combination for a pediatrician is very suspicious of KD, but for adult physicians, they may not be that conversant with the presentation of KD. It was only when she developed frank desquamation that her parents took her to a dermatologist, and he referred the patient with a diagnosis, suspicion of KD. This patient had small aneurysms in all 3 coronary arteries, but fortunately responded to IVIG and she did not have residual coronary artery aneurysms. Then you have unusual types of KD. And one of these is node first KD. That means the child presents with just a cervical lymphadenopathy along with fever. And when you have this kind of a presentation, unless you are familiar with the subtle variations of presentation, chances are that one may diagnose this patient as a bacterial lymphadenitis. But presence of high fever and lack of response to antimicrobials should be taken as red flags for KD. And if you look at the subtle signs of KD, you'll be able to pick them up in such patients. So whenever you have high fever and a lymph node in the neck, especially a single node, unilateral single node, keep KD at the back of your mind. There are ways to differentiate KD lymphadenitis from bacterial lymphadenitis. The most important clinical feature being that in a bacterial lymphadenitis, it's usually a single dominant node, while in KD, you will have multiple discrete nodes with one of them being quite large. On ultrasound, KD lymph nodes are uniformly hypoechoic, while in bacterial lymphadenitis, you have additional anechoic areas. So these are some of the clinical features to differentiate. But as clinicians, I think what we have to remember is if the fever is persisting in spite of antimicrobials, think of KD. And this presentation is known as node first KD. So over the years, a new concept has come, and that is the extended spectrum of KD. And we have described this entity in one of our recent publications in the expert reviews in clinical immunology. So these are the various presentations of KD. You can have it in unusual age groups, adolescents and adults. You can have polysymptomatic presentations. KD in infants is a different ball game altogether. You can have incomplete KD. Occasionally, you can have peripheral gangrene in KD. In our experience, this is distinctly unusual, but yes, we have seen a couple of these patients. Then you can have KD with macrophage activation syndrome. So when you have a persisting fever with an oncoming macrophage activation syndrome, think of KD. And I have already mentioned KD in the ICU presenting as KD shock syndrome or severe myocarditis. When you are in the emergency room and you have a child with congestive cardiac failure and the child has fever, this may not be viral myocarditis. In viral myocarditis, by the time the child develops congestive cardiac failure, fever is usually absent or only mild. So if you have high-grade fever with congestive cardiac failure, this may be the myocarditis of Kawasaki disease. So we have what is now known as the extended spectrum of KD. There are a lot of myths regarding imaging in children with KD. And I think echocardiography examination can be notoriously unreliable. We must remember that the first few signs on echocardiography would appear after day 7. And by that time, it may already be too late. So take your echocardiographic findings with a pinch of salt, especially if they do not gel in with your clinical possibility. The diagnosis of KD is the domain of the pediatrician, not that of the pediatric cardiologist. The pediatric cardiologist is there to assist us in assessing the involvement of coronary arteries. But he's not there to diagnose KD for us, just as a pediatric cardiologist is not there to diagnose acute rheumatic fever for us. That is our domain. That is our responsibility. And if you do the echo in the first few days, it may be completely normal. And if you repeat it after, say, day 7 or day 8, you can land up with giant aneurysms. So a negative initial echo does not rule out KD. We must be very careful about the experience of the echocardiographer. if the echocardiography has been done by an adult cardiologist or by a pediatric cardiologist whose main focus is congenital heart disease, some of the subtle findings may not be picked up. There is a lot of inter-observer variability, and Z-score calculation has to be done very, very carefully. If you do not record the weight of the baby very accurately, if you do not record the length of the baby very accurately, your Z-scores will be very unreliable. In our unit, we have the echocardiography machine in the ward itself. And the echocardiography is done not by the pediatric cardiologists, but by our rheumatology trainees, because we need to do the echocardiography daily for the first few days. And if you have subtle changes on echocardiography between day 1 and day 2, for us, those are very significant changes. So in a child with suspected KD, we may do echocardiography virtually daily for the first few days till we are sure what we are dealing with. So as I said, cardiovascular involvement in KD is much more than mere coronary arteritis. So you could have myocarditis presenting as myocardial dysfunction. You could have aortic root abnormalities, which have been mentioned in the 2017 guidelines of KD given by the AHA. Some children may have subtle pericardial effusions. You could have valvular regurgitations, and these may be clinically asymptomatic, but they could be because of KD. And of course, coronary artery abnormalities will always be there. KD is not a one-time disease of childhood. It's not that you pick up KD, you treat KD, and all is well thereafter. It can leave behind several sequelae. And as uncomfortable as it may look, KD often does leave behind several sequelae. And some of these children may be completely asymptomatic. So this was a 3-year-old girl presented in 2010. She was diagnosed with KD, received IVIG in time, but she had already developed giant aneurysms in the 3 coronaries. So she remained on long-term anticoagulation as well as long-term aspirin. At the age of 11 years, that means 8 years after diagnosis, by this time at our institute, we had developed this facility for 128 slice dual source CT coronary angiography. This is a very special kind of CT coronary angiography, which we do on a 128 slice platform. The trick is in decreasing the radiation exposure. So this is done using highly sophisticated softwares. There is only one radiologist who does this examination at our institute, and he is able to achieve a radiation exposure less than 1 millisievert. Now, I must caution that CTCA should not be done routinely unless you have this platform and unless a radiologist is able to do it at a reasonable radiation exposure. Otherwise, if you do routine CTCAs, your children will be exposed to something like 10 to 15 millisieverts. So this is what we obtained. Look at these calcifications. So we have what is known as a calcium scores. And the calcium scores in this child of 11 years was what you would see in an individual who is more than 70 years old. So these coronaries will never ever regain normalcy. So this child, when she grows up, one has to be very careful with how one would deal with it. Even a bypass graft here is not going to be the easiest of tasks. So horrific looking calcifications over 8 years after Kawasaki disease. So again, another patient with calcifications, which we recently reported in rheumatology. We have been following up these patients through non-invasive tests also, and we have found that the carotid intima media thickness in children with Kawasaki disease remains abnormal for many years after the acute episode. And this is worrying. What are the treatment options in this condition? Well, if you pick up the child early enough, so patients with both complete and incomplete forms of KD should be treated with intravenous immunoglobulin, preferably within 10 days of onset of fever. So we use 2 grams per kg of IVIG, aspirin initially in higher doses, but the higher doses that we use nowadays are not 80 to 100, but rather 30 to 50, usually towards 30 rather than towards 50. And we follow this up after a few days with antiplatelet doses, that is 3 to 5 milligram per kg per day. And this is the regimen which has been the gold standard for treatment of KD for almost 30 years now. And this is what has been recommended in the 2017 guidelines. What happens if the child reports to you after day 10 of onset of fever, an occurrence which you see day in and day out? IVIG should still be given, even if the child comes after day 10, especially if there is evidence of persistent fever, if there are any types of coronary artery abnormalities, or if there is ongoing systemic inflammation as manifested by an elevated ESR or CRP. So if you have any of these findings, there should be no hesitation in giving IVIG right away. But we are dealing with a major therapeutic paradox. Even with prompt administration of IVIG, that means even when you give IVIG before day 10, up to 1/5 of these patients develop transient coronary abnormalities. What is the long-term significance of these? We don't know. Up to 5% patients develop persistent coronary artery abnormalities. And up to 1% of patients develop giant coronary aneurysms, even when you have given IVIG within 10 days of therapy. Now, although the figure of 1% may look low, but for a disease which is as common as Kawasaki disease, this figure is not acceptable. This figure is not acceptable. So we are dealing with a very tricky condition. We are dealing with a very difficult condition. It is clear that IVIG alone may not be sufficient for treatment of acute KD, and there is a definite need for additional therapy in some cases. So this is what we call preemptive treatment intensification in Kawasaki disease. So that means when you see the child, in some situations, you would not rest content only with IVIG, but you would rather add on one of the therapeutic agents. So this is a study in which Dr. Jane Burns' group has done treatment intensification in patients with KD who had coronary aneurysms at diagnosis. That means when the first echo was done, the patient had some coronary artery abnormalities. So what they did was they along with IVIG, they gave either steroids or infliximab. And they found that patients who were given IVIG along with steroids or along with infliximab had less progression in the coronary arteries as compared to those who were given IVIG alone. So what it means is that if you have a patient with KD who has any kind of coronary involvement, you should consider being more aggressive in management. IVIG alone may not be sufficient. Then there is an entity known as refractory KD, which occurs in approximately 10 to 15% of patients. These are very high figures because KD is such a common disease. So if 10% of patients do not respond to IVIG, that's a very, very worrying figure. There is no consensus on how you manage these patients. but you could consider using a repeat dose of IVIG. You could consider using infliximab. You could consider using steroids. At our center, we usually give infliximab in these situations. What is clear now is that prompt initiation of second-line therapy is crucial. That means the moment you see persisting fever 36 hours after the first dose of KD, first dose of IVIG, you should consider giving either a second dose of IVIG or infliximab or steroids. Prompt initiation is crucial. The choice of treatment is perhaps less important. And this is what is given in the 2017 AHA guidelines as well. What is the role of aspirin in acute KD? This is controversial. We really do not know whether aspirin does any provides any benefit to the patient or not. There are several risks associated with aspirin, raised transaminases, GI bleeding, especially in young babies who may not have been feeding well, sensorineural hearing loss, and a theoretical risk of Bray syndrome. So in the United States, they still use somewhat higher doses, but rest of the world, we use just 30 to 50 milligram per kg per day. And many centers, in fact, now are suggesting that you could start with the antiplatelet dose from day one. What is the role of corticosteroids? Now, KD was till very recently the only vasculitis where steroids were somewhat contraindicated. And this has been because of the initial study by Dr. Kato, who showed that patients who had received steroids had a higher incidence of coronary artery aneurysms. But when they reanalyzed the data, they realized that patients who had received steroids were in fact those who had very severe types of KD. So it was no surprise that they showed more coronary artery aneurysms. But the fact that a celebrity like Dr. Kato had given this opinion meant that steroids became relatively contraindicated in KD till over the last 10 years or so, when several studies have appeared which have shown that addition of steroids to IVIG is beneficial for most patients with Kawasaki disease. In 2015, we wrote this review article essentially for developing countries where IVIG may not be easily available. And the net conclusion is that if IVIG is unavailable or unaffordable, steroids are a logical primary treatment despite the lack of trial data and the limited published experience. In other words, if nothing else is available, there should be no harm in using steroids. What is the role of infliximab? So we know that TNF-alpha has a big role to play in Kawasaki disease. TNF-alpha levels are higher in patients with KD and coronary artery aneurysms as compared to those without coronary artery aneurysms. And infliximab has been in use in KD for more than a decade. So this was the first study which Sohrab referred to, published by Dr. Jane Burns in 2008. And she was the first researcher to show that if a patient requires a second dose of IVIG, you could replace that with infliximab. And in our hands, we find that infliximab not only is perhaps more effective than IVIG, but for us, where cost considerations are also a significant aspect, infliximab often turns out to be less expensive than a second dose of IVIG. And this is our small study on infliximab, which was published in 2016, where we reported on 23 children with KD who had received infliximab. And we had, majority of them, we had prompt resolution of the fever. There are several other therapeutic modalities in KD. Cyclosporin has been a recent adjunct, and the proponents of cyclosporin have been the Japanese workers, and especially Hiromichi Hamada, who published this study in Lancet, wherein he showed that patients who had very severe types of Kawasaki disease, they benefit from addition of cyclosporin to IVIG. We'll hear more about anakinra, the IL-1 inhibitor, and anakinra is also being used in a big way in Kawasaki disease. And all these drugs, that means infliximab, steroids, anakinra, cyclosporin, they should be considered in patients who have either resistant KD or very severe types of KD, or when KD occurs in infancy, then you should not rest content only with IVIG. So to conclude, KD is a common childhood illness. How common? At PGI Chandigarh, we see upwards of 100 patients of KD every year, upwards of 100. And this is happening in a small city like Chandigarh with a population of 1 million. So one can well imagine the numbers that would be there in big metropolitan cities. 1% of all children born in Japan develop KD. It is as common as that. 1% of all children in Japan will develop KD before they reach the age of 10. Beware of young children with unexplained fever for more than 5 days. Before starting antibiotics or before changing antibiotics, give a knock on your head and ask, could this be KD? KD can often be a diagnostic nightmare, and one has to deal with it head on. KD is rather unforgiving. Missing out on a diagnosis can have disastrous consequences. However, since we have no biomarker, no laboratory marker for Kawasaki disease, the diagnosis remains more art than science. Kawasaki disease remains a riddle wrapped in a mystery, inside an enigma, even after 54 years of the diagnosis of the first description of Kawasaki disease by Dr. Tomisaku Kawasaki. So when should one suspect KD in children? Fever for more than 5 days in children below 5. Irritability out of proportion to fever may not always be because of meningitis. Fever with rash may not always be measles or a drug rash. Fever with swelling over dorsum of hands and feet, red lips and red tongue. And as I said, this is swelling over dorsum of hands and feet is the most specific finding of KD. Sudden appearance of unilateral cervical adenopathy in a febrile child. This need not always be suppurative lymphadenopathy. It could be the presentation of KD. So as Dr. Sohrab mentioned, the International Kawasaki Disease Symposia are held every 3 years. And at most of these symposia, the star attraction was none other than Dr. Kawasaki himself, who would sit through the proceedings from morning till evening. And we had the privilege of meeting him at the last symposium, which was held at Yokohama, June 12 to 15. And this is what he had to say at the inauguration.
第12回国際川崎病シンポジウムは2018年6月12日から15日までパシフィコ横浜で開催されます。いまだに原因が明らかでない川崎病について小児科だけでなくさまざまな領域の研究者が世界中から集まり4日間にわたって熱い討論がなされます。熱い討論の後には横浜でならではの雰囲気とおいしい食事を楽しんでください。数多くの皆さんが国際川崎病シンポジウムに参加されることを希望します。横浜でお目にかかりましょう。以上。
And this is Dr. Kawasaki at that same symposium. These are his 2 daughters. This is June 13. This is Dr. Kawasaki with Dr. Hirohisa Kato, who has been a long-time researcher and a long-time associate of Kawasaki disease and a long-time friend of Dr. Kawasaki. So in 2005, when we invited Dr. Kawasaki, we requested him to get Dr. Kato also along with him. And we were privileged to have both of them in Chandigarh in 2005. And this is Dr. Kawasaki with some of our residents at Yokohama. And this is the last photograph that I have of Dr. Kawasaki. Thank you very much.
Thank you very much, Professor Sujit Singh. It was an excellent, outstanding talk. Really, we all enjoyed, all the viewers, I'm sure they have enjoyed. And till Dr. Kalpana and Dr. Amir, they prepare the questions, we'll have just a short 2 minutes video. Then I will request Professor Taneja and Professor Wali to join us for question and answer. Over to Tawfiq, please. Mr. Tawfiq, please. Mr. Tawfiq, please.
Vitabiotics, an award-winning nutraceutical company. It is the first nutraceutical company to complete 50 successful years. Well Baby Vitamin D3 Drops is a unique vitamin D3 supplement in an olive oil base. No peanut oil, no castor oil like other formulations. Well Baby Vitamin D3 Drops provides 400 international units of vitamin D3 in 0.5 ml and 800 international units per 1 ml. Devoid of any artificial flavors and colors. It contains no artificial sweeteners. Suitable for vegetarians. Suitable from birth onwards. It contains easy-to-use measuring syringe. Well Baby Vitamin D3 Drops is covered in all insurances, including PCP, RN3 and Abu Dhabi Basic Plan. Well Baby Multivitamin Drops is the ideal supplement formula for babies from 1 to 12 months. It contributes to normal cognitive development of babies. Supports normal growth and development of bones in babies. Helps to boost immunity in babies. It is an appetite enhancer. Supports overall health and wellness in babies. Contains no artificial colors or sweeteners. Dose. For babies from 1 to 12 months, give 0.5 ml twice daily. Vitabiotics is proud to present the comprehensive multivitamin formula for babies aged 6 months to 4 years, Well Baby Multivitamin Liquid. It contributes to normal cognitive development of children. Supports normal growth and development of bones in children. Helps to boost immunity in children. Provides required nutrients for picky eaters. Supports overall health and wellness in children. Dose. For 6 months to 4 years, give 5 ml daily, 1 teaspoonful. Well Kid Omega-3 Chewable Capsules. Vitamin D helps in increasing the immunity. Omega-3 improves concentration and attention span. It builds eye health by improving tear stability, optimizes the brain functions, boosts the synthesis of dopamine that helps in ADHD symptoms, acts as an anti-inflammatory source. The dose is 2 capsules daily for kids aged between 4 to 12.
Thank you very much, Tawfiq. Now I would like to request Dr. Sujit Singh, Dr. Taneja, Dr. Walid to join us. I would like to request Dr. Kalpana Amir to start the session. One good news I would like to give the viewers, our first biannual conference will be held on the last Friday of May, and Professor Surjit Singh is our chief speaker giving the oration talk. Thank you very much. Over to Dr. Kalpana.
Thank you, Dr. Sohrab. Thank you, Professor Surjit Singh, for this very comprehensive analysis of Kawasaki disease. In fact, I think just a lecture is not enough. Maybe one-day conference will also not be enough. Your knowledge is so vast and your experience so vast. We are really grateful to you. Now, there have been many questions regarding Kawasaki disease. But the first question that I would like actually to pose to Dr. Waleed, this is regarding the Gulf experience or the incidents, like Dr. Surjit Singh has mentioned that in a city of North India, they get 100+ cases a year. What has been our experience in UAE or in GCC in general, if you have any data?
First of all, good morning to everyone, and I would like to thank Dr. Sohrab for this fascinating review of the history. And everyone knows that Dr. Sohrab, he is the best to talk about history, particularly in medicine. And to our Professor GC, and to Dr. Kalpana, Dr. Tawfiq, and all the organizer committee. It is very fascinating history about Kawasaki disease, very impressive review lecture by our professor. We are honored to have him today. Dr. Kalpana, the issue with the Kawasaki disease here in Dubai or in UAE, that we don't have really a registry for Kawasaki disease, and it is not reportable disease. So it's really very hard to know the incidence. So I don't have data about it. We have a few studies from here and there, which will not reflect the actual incidence about Kawasaki disease in the UAE or in Dubai in particular. But I would like to tell you that at Al Jalila Children's Hospital, for 2 years, we had 50 cases of Kawasaki disease, including what our guest speaker, we have atypical, we have incomplete, and Kawasaki disease shock syndrome. At least we have 4 cases of Kawasaki disease shock syndrome. So unfortunately, unless we have registry and this disease to be reported, we will not have the accurate incidence about Kawasaki disease in our area.
Yeah, so as you have brought up the question of registry, Professor Surjit Singh, I would like to ask whether it is really important, and do we have a regional or a national level registry of Kawasaki disease in India?
Well, as Dr. Walid has brought out, ideally, yes, we must have a registry. But for a country as big as India, having a registry about any disease is so very difficult unless you have, unless it's a national program. Otherwise, it's very, very difficult. But in India, several large centers, I'm aware of the center at Calcutta. So they have been collecting data systematically. We have been collecting data systematically. And based on these hospital-based registries, we have been able to extrapolate the epidemiology. So as I said, based on our extrapolations, our incidence is approximately 9.3 per 100,000 children below 5, which is almost the incidence of several European countries. Now, but this is the lowest incidence because we are presuming that other hospitals in Chandigarh are not diagnosing KD. Now, they may be diagnosing, but many of these patients ultimately land up in PGI. So, but many patients may still be getting missed. So of the recorded patients, the minimum incidence is around 9.3 per 100,000 children below 5. Thank you.
Thank you. Yes, Dr. Amir. Okay. Going further from here, there have been many questions regarding the clinical features because as you mentioned, it is KD should be taken as an emergency and no pediatrician should miss the diagnosis of KD. In your lecture, you also said that it can be picked up on day 2 or day 3 of fever. And that was, I would like you to just tell us which are the scenarios on day 2 that we would say, oh, this is KD.
Yes, we picked up our first patient in 94. For the first 10 years, I think we were very, very conservative in our diagnosis. And we would treat patients only if they met all the criteria. Until Dr. Kawasaki himself visited us, Dr. Jane Burns visited us, and they opened our eyes. So we had read about incomplete KD, but it was only after these visits that we realized that we perhaps have been missing many patients. Some children with Kawasaki disease can have a book picture presentation. That means redness in the eyes, red lips, swelling over dorsum of hand. In such patients, if you have the requisite experience, you need not wait. You should not wait before giving IVIG. So you can give IVIG on day 3, day 4, but that depends on your own experience of your hospital and the circumstances. But if you are confident, you are well within your rights to treat these patients before day 5.
Kalpana, may I interrupt ask one question? Dr. Taneja is here. 1 year after publication of Dr. Melish in 1976, Dr. Taneja described first case from India in 1977. I would like to request him to tell how he diagnosed his first patient.
Am I audible?
Yes.
I trained in Boston, United States during my residency between 74 and 76. I saw a case of Kawasaki disease diagnosed at Boston Children's Hospital. When I came back here, I was working at Gangaram Hospital in New Delhi, and
Some interruption.
PUO patient was presented, and I just had to join around. This patient, because of which the fever subsided. There was no IVIG at that time. So those were the
Taneja, we lost you
circumstances.
there for a minute. Could you just start again?
I said that I had come back from Boston.
His interruption in the video.
Yes, I think.
And attended rounds. Yes? Am I audible?
Yes, doctor.
Yes? Okay, so at that time, after the diagnosis that I made, we gave the child only aspirin, with which the fever subsided and stayed down. At that time were the circumstances.
Thank you very much. There was interruption, Dr. Taneja. So Dr. Kalpana, you can carry on, please.
Yes, Dr. Amir.
Can we ask some question from the audience? The pathophysiology of BCG activation in Kawasaki disease, please, Dr. Professor Surjit, if you can answer.
Well, this is something which no one understands. And it is seen in infants. It is not seen in older children. The BCG site reactivation is seen only in infants. Whether it is because of some kind of molecular mimicry, we don't know. No one knows the reason. And what we also know is that it is far more common in Japan, South Korea, Taiwan than it is in India. For instance, at our center, we do not see this very often. So, but to answer your question, no, no one knows why it occurs.
Can I just interject here? Hello.
Yes, doctor. Please
Yes,
go on.
Dr. Kalpana, I think the BCG reaction occurs because of T cell activation. There is a recruitment of T cells with Kawasaki disease, and they home in on the BCG area, and that's what gives rise to the BCG activation.
Yes, I think literature also speaks about cross-reactivity between the mycobacteria and human heat-resistant protein. Like Professor Surjit said, that also works, but we don't know for sure what really is the cause. But interestingly, not all the countries in the world are following BCG vaccination, but those where they do, this becomes an important thing to pick up. Moving further, Dr. Rambabu wants to know whether thrombocytosis alone is enough in a case of fever to pick up KD. And since he brings up the role of platelet count, I would like to couple it with another question by Dr. Manoj, who says, can platelet count be used to differentiate between Kawasaki disease and Kawasaki type of MISC? So I think we can have opinions from all the three panelists on this.
The platelet count, the platelet count may not be high in the first week of the illness when they present with fever. It usually rises after 5 to 7 days. And there are occasional patients who will present with thrombocytopenia. And in those patients, it usually leads to more severe Kawasaki disease if it presents with thrombocytopenia.
I agree with Professor Tanjay that, thrombocytosis is not pathognomonic or diagnostic, but at least it is an eye-opener for the treating physician when you have a child with fever not diagnosed, and particularly if you have 2 CBCs done and you find raising platelet count, just an eye-opener to raise high index of suspicion to think of Kawasaki disease. Again, thrombocytopenia can be there, and this is a bad sign, prognostic sign, as my colleague mentioned. There is no way to differentiate between MISC and Kawasaki disease just because of the platelet count. And I would like to bring to my colleagues here who are listening and watching us, and I can ask for the opinion of my distinguished speakers here to have their opinion, that after COVID-19 pandemic, no more we say Kawasaki disease. All of these terms, the recommendation is to be MISC. I would like to hear the opinion of my distinguished speakers here also.
I think one more thing, when you get MISC or you get meconium, or you get macrophage activation syndrome, then there is a bicellular depression.
I agree, particularly with we see leukopenia, and we have seen also depression, B and T cell subtypes, as well as in certain patients depressed immunoglobulin.
Count also goes down, and the thrombosis.
So, Professor Surjit Singh, may I ask you, what is, let's make it simpler for all of us. When we say Kawasaki disease, is it the same as MISC? Is it the same Now, with COVID-19 coming in, the other terminologies, PIMS, so can we just, simplify the nomenclature and then go forward?
Well, that's, as Dr. Walid has pointed out, we are only beginning to understand what's happening.
Absolutely.
And things will be more clear once the pandemic is over. But there are patients with MISC who have a more KD-like presentation, and there are patients who do not have a KD-like presentation. So when you have a MISC with a KD-like presentation, well, yes, that is almost like KD with some differences. But otherwise, I think it will take us some time to, we may be making some premature conclusions at this time. Only once the pandemic is over will we be able to understand what really we were dealing with.
And any thoughts on why this is presenting in a KD-like fashion? Because that would lead us to believe that a virus can give us a similar picture. Some infectious agent which can cause some, immune response and give us a KD-like picture. Is that true?
Absolutely. The group at Chicago, so Dr. Anne Rowley and Dr. Stanford Schulman, they have been hypothesizing for more than now 18 years that KD is an infectious disease. It's linked to some infection. And they were the first ones to link it up to coronavirus. And this was in 2005. They mentioned that, yes, coronavirus could be the virus for KD. But what has been understood of now is that apart from an infection, you also have to have a genetic component to KD. So infection in the setting of some kind of a genetic background, yes, that is what results in KD. And the recent increase of MISC that you are seeing is perhaps because of the type of virus that we are having, that is the coronavirus. And there's no doubt that some of these children have an illness which is very, very similar to KD.
I agree with my friend here, and I strongly believe after having the MISC due to the COVID-19, I strongly believe more and more that Kawasaki disease is due to coronavirus or microbiological reason. And I strongly believe both they have genetic underlying predisposition, because nowadays I have seen MIC or MISC in families that, many siblings, they had corona, but one of them developed MIC, which definitely, maybe there is genetic predisposition. And I would like to tell you that we are at Al Jalila Children's Hospital. We have been doing this what's called with whole exome sequencing for patients with MIC. And so far, the preliminary results that most probably there is a genetic predisposition. There is a very good study that published in JAMA about genetics and Kawasaki disease, and they claim that there is genetic signature for Kawasaki disease. So I strongly believe there is genetic, and that's why it is more common in Japan, Korea, and Taiwan, and these countries. The other fascinating observation from the talk from my colleague here, that BCGitis, I have seen many hundreds of cases of Kawasaki disease in the United States and here in UAE. I can't recall maybe one or two or handful cases that they have BCGitis or erythema of the BCG, while it is common in Japan. This is really an interesting observation.
May I interrupt here to ask one question? Since Dr. Sujit Singh has attended many conferences, This happened after, 1950s, cases started picking up 60. There was Hiroshima bombing in Japan, atomic bomb. In the 302 per 100,000, all over the world, 5 to 15, as you said, India 9. Is there anything to do with this irradiation after that which affected the gene? As we see in the Hawaii also, Dr. Melish found it in the Japanese ancestors, not other people. It was in Japanese. Since the genetic topic is there any relation between atomic bomb and genetic changes in Japanese?
Well, the link that has been given, the epidemiology, as you mentioned, Japan is now more than 350 per 100,000 children below 5. The worrying part is that in Japan, it is still continuing to increase. The incidence of Kawasaki disease in Japan is twice what it was 20 years ago. It has not plateaued. It is still continuing to increase. The country with the second highest incidence is Korea. Now, Korea has something like 130 per 100,000 children below 5. Taiwan has the third highest incidence, around 80 per 100,000 children below 5. So these are the three countries with the highest incidence of KD. All of them are in Asia. All of them are in Northern Asia, Eastern, Northern Asia. And all of them have some similarities in their genetic backgrounds. All over the world, rest of the world, the incidence is less than 30 per 100,000 children below 5 years. So that is one difference as far as the epidemiology is concerned. The second difference is that in Japan, the incidence is still continuing to increase. It has not plateaued. In the US, it has plateaued. In Europe, it has plateaued. We don't know the reason. One interesting reason is the economic development of a given country. Japan reported its KD in 60s, just after it had stabilized economically after the ravages of the Second World War. In 1964, Tokyo hosted the Olympics. So they had built up their economy by 1960s. 10 years later, Korea was the country which came up in a big way on the economic field, and they started reporting KD. Another 10 years later, Taiwan had an economic surge. They started getting KD. When did we start getting KD in India? 1990s. When was our economy liberalized? 1990s. So there is some link with the economic development of a country and recognition of KD or ascertainment of KD, whether that has to deal with a hygiene hypothesis, a change in the immune system as a result of more vaccinations, because the moment the economic background improves, the number of vaccines that children in that country will receive will be much more. So whether that alters your TH1, TH2 balance, and that somehow alters our immune status, we don't know. To the best of my knowledge, no one has linked it to the nuclear this thing in Hiroshima. But yes, to the economic background of a given country, there are well-established links.
Thank you very much.
Right.
Okay. There is a question from Dr. Manoj asking about, can we diagnose Kawasaki disease in scenario of only fever for more than 1 week without any other symptoms, only elevated inflammatory markers and elevated platelets and normal ultrasound or echo, heart echo? I think you mentioned it in your presentation, Dr. Professor Sujit. Anybody can answer?
Yeah. So as I said, you have to have an open mind for Kawasaki disease. If you're dealing with a febrile child, and especially if it is an infant, your threshold for KD will be much lower. And some of these children can have very, very subtle signs. So if you have long duration, I mean, if you have ongoing fever, which has crossed 7 days, you will work up, you will exclude all the possible other infectious agents, have an open mind for other conditions, but still if you are stuck, and if there is thrombocytosis, if there is, we routinely do pro-BNP levels. We do it in all children with KD because it is available in our institute. If the pro-BNP is high, at our center, we take a threshold of around 1300. If it is above 1300, pro-BNP is high, CRP is high, yes, we would consider treating this patient if other causes have been ruled out. So it all depends on the clinical situation, because infants often do not fulfill the criteria. But I would like to have the opinion of Dr. Walid as well as Dr. Arvind.
I agree with you, strongly I agree with you, my dear, because as you mentioned clearly in your presentation, the outcome is very devastating if we miss the diagnosis of Kawasaki disease. And for our colleagues, we should have very high index of suspicion and very low threshold to make the diagnosis of Kawasaki disease in such case scenario, particularly if the inflammatory markers are really high and we exclude other etiologic findings. And this is what I'm telling my students and my residents all the time, that if this is Kawasaki disease, we save the life of this patient and also the devastating complications. If it tends to be Still's disease, time will tell us and nothing to lose. So it is better to be proactive rather than reactive when it comes to Kawasaki disease, because the complications very devastating and the price very high.
So since
I
we
would,
have...
hello,
Sorry.
I would like to point out that NT-proBNP is not available easily in most laboratories and hospitals. So I rely on a very high CRP or BNP in a child who's got more than 7 days of fever. Plus, usually there is some leukocytosis in the first 7 days of fever, which are indirect markers for the possibility of Kawasaki disease. I'd like somebody to comment on that. Dr. Surjit Singh, if he would like to say.
Yes, sir, I would agree with you that children with KD have polymorphonuclear leukocytosis, and they have raised CRP, usually a raised ESR as well. And it's a clinical diagnosis. KD, like any other vasculitis in children, it's a clinical diagnosis. So you would rule out other conditions. You would see the child maybe twice a day, look for soft signs, get their echo repeated, look for subtle signs on echo like brightness of the coronaries, loss of tapering of the coronaries, some subtle regurgitation, subtle pericardial effusions. And if nothing else fits in, yes, please do consider a diagnosis of Kawasaki disease. You may be exposing yourself to some degree of overdiagnosis. I agree. But that is what these criteria are like. For a disease like KD, 5 to 10% overdiagnosis will be far, far safer than 5 to 10% underdiagnosis.
I have noticed, this is typical case scenario for infants, usually less than 1 year of age. And what I found that the irritability is out of a proportion to the degree of fever. And this is alarming. We have to pay attention. Usually the infant is very miserable, like cases of measles, and cranky, and it is very apparent. So it is not like, meningitis and consolable, or because of the fever. This is also should be an eye opener to make the probability of Kawasaki disease in such case scenario.
I would like to interrupt and say, I had a teacher in Iran said, if a child with fever doesn't smile, think of Kawasaki unless proved otherwise. If a child with fever smiles, you can think that it is not Kawasaki. This smiling is, I mean, back of my mind, always I see Kawasaki patients, they don't smile. They are able till they are treated.
What do you think the cause is? Irritating of the brain or what?
They say encephalitis, a form of encephalitis. I know Professor Surjit and others are there to say.
Yes, they say it is probably because of aseptic meningitis. But what Dr. Walid has said is very true. These children are often very irritable, especially infants, very irritable. And this irritability is somewhat different from the irritability that you associate with meningitis. And a clinical pointer that sometimes may be useful is the moment you start intravenous immunoglobulin, the baby just goes off to sleep after 2-3 hours. And what we see is that the baby has gone off to sleep and the baby is in the mother's lap, and on the baby, the mother goes off to sleep because she has been awake for the last 2-3 days. So it's such a typical situation in these patients. Yes, Dr. Walid, I agree with you completely. Irritability is a soft sign, but remember, neither irritability nor BCG reaction nor perianal desquamation are there on the criteria. So the criteria are still very, very loose.
Agree.
So there is a comment by Dr. Siddharth Arora who has shared that he in fact wants to ask if is there any difference in KD with PIMS DS, as they, in their data of 126 children, they found that methylprednisolone response was much better. So in areas where IVIG is not immediately available, can we go ahead with steroids, and is it as it is cheap as well? So the role of steroids.
Well, I would refer you to that article in Pediatric Infectious Disease Journal, January 2015, where this aspect has been covered. And this article was written jointly with Dr. Jane Newberger, and the language used in that sentence, that was her language. And she must have framed that paragraph. I think she must have edited that paragraph umpteen number of times. So the message is IVIG remains the drug of choice, but if a patient is unable to afford IVIG, there is just no way you can procure IVIG for your patient. Do not hesitate from using steroids. That is the message. But since there are no head-on-head trials, steroids will not be the drug of choice as of date.
A couple of related questions, whether IVIG of 1 gram per kg would be enough.
Dr. Kalpana, can I just
yes,
have
doctor.
a comment here? I strongly agree with Dr. Suchi. I believe, steroids will have more and more role in treating Kawasaki disease, simply because multi-system inflammatory syndrome in children or adults with COVID-19 who got admitted to the ICU, all of these sharing what's called cytokine storms. And we know by now, steroids has big role in adults with COVID-19 and cytokine storms. Also, my experience and also the guidelines for MIC in children, that IVIG is the first line of treatment, but if the patient does not respond, the second line will be steroids. So I believe that, steroid will have major role in treating patients with Kawasaki disease.
And there was a question regarding the dose of IVIG. Can they give 1 gram per kg, or do they stick to 2 gram per kg, as well as which steroids to choose? What would be the dose? What would be the duration?
You know, it has been studied, you know, 1 gram versus
This
2
is
gram.
accepted that IVIG.
Go ahead, sir.
I think it is widely accepted that the dose of IVIG should be 2 grams per kilogram body weight. The maximum IVIG that you should give is 80 grams. I think that is accepted too. Of course, the other question was, what exactly was the other question? Steroids.
The steroids.
You should use methylprednisolone in a child. It's 15 milligram per kilogram body weight with a tapering dose over 15 days of or so. And if methylprednisolone is not available, which is also probably sometimes true, then using prednisolone will be equally effective.
You know, it was studied that, you know, comparing 1 gram versus 2 gram, and it showed that 2 gram is superior to 1 gram. I strongly believe, you know, in Kawasaki disease, we have to be really aggressive because it is simply, it looks like cytokine storm. And the more we aggressive, the more we can control this cytokine storm. And for the steroids, strongly agree with the regimen.
There's
Islam, just Dr. Amir,
there's
related
a question
Dr.
from Oday, Dr. Oday, about infliximab and the cost of treatment and any limitation of the age. Any limit for the age of using infliximab in Kawasaki disease, and what the cost?
Well, we have used infliximab even in very small babies, a few months old babies. The dose that we use is 5 to 10 milligram per kg. In younger infants, we would be going towards 10 milligram per kg. In older children, towards 5 milligram per kg. Each vial is 100 milligrams. It's given intravenously. The only precaution that you need to observe is that you have to pre-medicate the child with hydrocort as well as an antihistaminic. Some children can develop anaphylactic reactions to infliximab, so you have to be rather careful. But the response is usually rather dramatic after infliximab. So over the years, we have shifted from a second dose of IVIG to infliximab in children who need more treatment.
The cost?
Cost in India, in Indian rupees, 100 milligram is around 30,000 rupees. 100 milligram of infliximab is around 30,000 rupees.
So, Doctor, there's another question from Dr. Saif, who would like to know whether you've come across any complications of IVIG.
You know, I have come across the complication. The most important is immediate allergic reaction, and there is a special protocol that everyone is following, and physician very aware about such complication. And this is the most important complication. I have seen very occasional, you know, aseptic meningitis, and it is very important here to counsel the parents upfront about all the complications of the IVIG. Then there will be no surprise to them, particularly aseptic meningitis, which I would say not uncommon complication, and reassurance because nothing will be done. I have seen very, very occasionally reactive arthritis. These are the most important complications I have seen. Otherwise, I would consider pretty safe IVIG. Also mentioned theoretically, you know, that you could have bradycardia, tachycardia, you could have hemolytic anemia. I have one case, you know, I presented to in pediatric club from IVIG that crystal deposits in the cornea, in the eye, which is extremely very rare. But I would say the most important is the immediate allergic reaction.
Interesting, because how would you pick up aseptic meningitis being a part of KD or a complication of IVIG?
You know, usually with Kawasaki disease, we know aseptic meningitis is there, but with the complications of IVIG, it comes after 2 or 3 days. And it is very typical, the patient will have very bad headache. This is a new symptom for the patient after the improvement from the fever. Sometimes they have headache, sometimes they have vomiting or photophobia. I don't recommend to do any spinal tap or any investigation, just pain medication will be more than enough.
There is a question from Dr. Maria about the possibility of recurrent after complete recovery of Kawasaki disease.
Reoccurrence can occur in Kawasaki disease even after dose of IVIG. Therefore, they recommend that from the beginning of the infusion till 48 hours, you should keep recording the temperature. Because if the temperature comes back, then there is a refractory Kawasaki disease. And the recrudescence of Kawasaki can occur even up to 15 days after treatment.
After complete recovery.
Yes, after complete recovery, in the first 36 to 48 hours, you should keep recording the temperature, because if the temperature comes back, it means there is a reoccurrence of Kawasaki.
And after that,
before,
and after that, after this period, any possibility of recurrence?
There is recrudescence, as they are called, within 15 days. Yes, there may be a reoccurrence within 15 days.
You know, a recurrence of Kawasaki disease is extremely rare, except for Japan is a little bit high to have recurrence. But other parts of the world, it is not really common, maybe less than 1%. And this is very common question from parents. Usually they ask, it comes back or not? If you are not in Japan, I'll be more than happy to reassure them that it doesn't come, because it is extremely rare. In Japan, it is a little bit, maybe 3%, maybe the recurrence rate of Kawasaki disease. But Professor Sochi can correct me, or he can comment on this, which again, it tells you most probably this is genetic predisposition rather than just simple disease.
These recurrences.
Yeah, I agree. Recurrences are rather unusual. And we have a small publication from our own institute on recurrences in KD. So it's less than 1%. It's not a very common occurrence. But yes, in some children, it has recurred after many months. So unusual occurrence. So it's quite reassuring for the parents that in most patients, it will not recur.
So I would like to ask, okay, we have diagnosed KD, we have given the first line treatment, child has responded. Now, how do we follow up this child? How frequent follow-up is necessary? How often we do 2D echo for him? How long do we follow up this child?
Well, at our center, the first few days, as I said, while the child is in hospital, we would do the echoes on a daily basis. And if at the end of day 10, after you have given the patient treatment, the baby has recovered, just before discharge, we'll repeat the echo, call him after around 2 weeks, repeat the echo at that time. And then if the 6 weeks echo is normal, then that is a crucial echo, because that is the time when we'll take the decision to discontinue low dose aspirin. If at the 6-week echo, there is any doubt about coronary artery involvement, we would continue long-term low-dose aspirin. And after the 6 weeks echo is normal, then theoretically, there is no need to repeat the echoes. But we would also at that time like to repeat the lipids. Lipids are quite often abnormal in these patients. In fact, we have 2 studies from our own center where we have done the lipid profiles in children who have recovered from Kawasaki disease. And we have found that several months down the line, some of these children had low HDL, high LDL, high triglycerides for reasons which are not clear. And this has been reported from several other centers as well. Whether these are all sequelae, consequences of a cytokine storm, we don't know. But children with Kawasaki disease continue to be at our center on lifelong follow-up, because we, many years down the line, we try to do their carotids, assessment of their carotid function. We have a small publication on their aortic function, and there are subtle abnormalities in several of these large arteries. What is the significance of these coronary arteries? We don't know. For patients who have had coronary artery involvement, we have been doing CT coronary angiography. It's a completely non-invasive test. And with the kind of radiation exposure that we have now been able to develop, minimal radiation exposure, we find that if you do CT coronary angiographies, many of the subtle findings may have been missed on echo. For instance, echo doesn't pick up distal coronary changes. Echo doesn't pick up the left circumflex coronary artery. And for these changes, you have to do the CT coronary angiography. So in selected patients, we have been doing CT coronary angiography, but follow-up of these children essentially is lifelong because there are many things which we don't understand. Myocarditis associated with KD, we just don't understand the long-term implications.
So these children are followed up in the pediatric rheumatology OPD or cardiology?
Ma'am, most of these children get followed up in our follow-up clinic, which is the pediatric rheumatology clinic, and we involve the other specialists on a case-to-case basis.
So in private practice or private hospitals, what would you suggest us to do? Because obviously, unless such services are established and patients can be referred at one place, one point, and they are followed long-term, when we treat them as pediatricians, what should be our advice to the parents?
Well, I think the first few weeks, you have to be very meticulous in your assessment. And if at 6 weeks, everything is normal, that means there is no suggestion of coronary involvement. There is no suggestion of any significant myocarditis. These children will generally not have significant sequelae, but you can have all kinds of surprises in KD, all kinds of surprises.
Here is a question from Dr. Kanan asking for sharing experience with neonatal Kawasaki. Any experience with neonatal?
At Chandigarh, the youngest child that we have seen was not a neonate. I think it was around 42 days or so around 5 to 6 weeks. We don't have any neonatal KD, but I'm aware of reports of neonatal KD from Japan. And I think in the late 90s, and this was a very interesting report because the second neonate that they reported was that we are reporting this baby at 23 days old. And this is the youngest baby ever reported. Our previous publication was of 25 days old. So that is how they reported, So yes, it has been reported in neonates.
If you recall, Dr. Kalpana and Dr. Sohrab, I presented 1 month old, and interesting, he presented with Kawasaki disease shock syndrome.
Shock syndrome.
Yes, Kawasaki disease shock syndrome in a month.
As a rule, I think infants can have more severe presentations. So we have to be more careful, right?
Yes.
Yes. So there's a question from Dr. Muhammad Ashraf who would like to know whether in a classical KD, have you ever come across measles IgM being positive?
Say it again, Dr. Kalpana.
Measles IgM antibody. Have you ever noticed it being positive in any case who presented with typical features of Kawasaki disease?
Yes, I have seen one case here in UAE. The baby has typical complete Kawasaki disease manifestation, but IgM for measles came back positive.
Excuse me, how you will differentiate from, suppose the child has received few days back measles vaccine. How will you differentiate that antibodies with, I mean, this in the child? Suppose child is vaccinated.
That child, he was, I'm not sure. This is 8 years ago. I can't recall, Dr. Sohrab, if he had measles vaccines or not. But he presented with full criteria of Kawasaki disease. And one of the residents ordered measles IgM and came back positive.
So will you diagnose it as measles or measles?
It's very hard, and very tough call. It is measles or it is Kawasaki disease. I can hear my Professor Sochi in this.
Dr. Sujit, any comment?
Yeah, KD has been associated with several viral infections. So it has been associated with dengue fever, measles, and as well as varicella. So you can get KD in the context of several viral infections. We ourselves have reported KD in the context of dengue fever. So these infections just serve to act as triggers for the KD. So it's infection triggered KD, if you could, use that term.
I thank you so much, Professor Sutsi. I have seen many cases concurrent infection, group A strep infection and Kawasaki disease, EBV and Kawasaki disease, parvo B19 and Kawasaki disease. But in this case in particular, when this measles, the primary physician, he was not convinced to give IVIG, and the child unfortunately was not given IVIG.
So there's a question from Dr. Deepu, who's asking about hyponatremia and hypoalbuminemia. They are common in most cases. So is the severity of hyponatremia, can it indicate the severity of KD or prognostically relate to any consequence? So hyponatremia and hypoalbuminemia.
Those one, I will consider a few markers.
Yes,
Among others that, could give hint that the patient will have refractory Kawasaki disease.
Yes,
refractory treatment.
What are the other markers that would at the onset tell you that this could be a refractory Kawasaki?
Very high inflammatory markers, C-reactive protein, thrombocytopenia, pro-NB also, albumin, low sodium. Those are the markers, that this patient, young babies, will be refractory to, could have refractory Kawasaki disease.
Right. And he would also like to know that after the first dose of IVIG, do we wait for 24 hours to assess the response, or you start methylpred straight away if fever spikes are continuing?
As the Professor Sochi mentioned in his lecture, clearly 36 hours we wait, and other people 48 hours. I personally wait 48 hours. Fever, within 36, 48 hours is allowed, but after that, no. Second IVIG should be given. Fever in the first 24 hours, it is not alarming. In the first 36 hours, not alarming. I personally wait 48 hours, and I have very good experience that after 48 hours, there is no fever. And this is very reassuring, because if this is refractory, fever will not go away after 48 hours.
Dr. Manoj asking also how long lymphadenopathy may be persist maybe it disappears within few days, and it's Kawasaki also.
Is the lymphadenopathy persistent, or it can disappear in 1-2 days? And
Dr. Sujit,
is it possible the lymphadenopathy to disappear within 2 days in Kawasaki? That's the question.
To disappear within 2 days, this is not unusual. This is not usual. But I have seen, within a few days after treatment, there is marked decrease in the lymph node and the tenderness. But in 2 days to go away immediately, I have not seen this.
right. There were a few questions about the anticoagulation. Do we always stick to aspirin? What is the role of warfarin or low molecular weight heparin? Which cases we would consider those?
Sujit's mic is off.
Yeah, maybe Dr. Walid can take this. Yeah.
Yeah. Usually aspirin, but if we find that D dimer is really very high and there is aneurysm, then enoxaparin or that has a place with the low dose aspirin.
Yeah, so that, like in giant, if you have diagnosed a giant aneurysm.
Exactly, giant aneurysms.
Yeah, so here
yes.
I just wanted to know the Z score,
I would say,
Yes, doctor, go ahead.
I would say that not only giant aneurysms, even large aneurysms.
Yes.
Because one should not strictly go by the definition of giant aneurysms, because assessment can be very subjective and it's open to a lot of errors. So whenever you have large aneurysms, in addition to aspirin, you would anticoagulate the patient. And we would generally use low molecular weight heparin in these babies.
Right. And what is the importance of Z score? Or like you mentioned that it could be difficult to exactly say, or may vary between studies, or depending on the person who's doing the 2D echo. So do we really go by the Z score?
Well, for accurate assessment of the coronaries, you have to go by the Z scores. And this is the standard now, assessment of the coronaries by Z scores. Again, there are issues here. For instance, we do not have the Z scores for the circumflex artery, left circumflex. That can be involved sometimes. And unless you have taken a very accurate record of the weight and the length, Z scores can be very unreliable. For many years, the Japanese workers were using absolute figures for the coronary arteries. For instance, any enlargement more than 8 millimeters, they would take as giant aneurysms. So like so many other things in Kawasaki disease, these are gray areas, and you have to evaluate, keeping the whole patient in context. Absolutely. And have a reasonable, element of doubt about the figures that you are getting for the Z scores and how accurately they have been assessed. One has to go into the nitty-gritty of who did the assessment, when was the echo done, things like that.
I think it's time to conclude, Dr. Sahra.
There's Dr. Fadil has a comment for Dr. Walid.
Dr. Kalpana said, well, actually, we have exceeded our time. There are so many questions. Dr. Kalpana, you can ask 1 or 2 questions more. Rest of the question we will send to Dr. Sujit Singh, because it is getting near 1 o'clock. In India, it is now 2 o'clock. They have to go for lunch also.
Absolutely. No, doctor, I think we have covered a vast variety. In fact, his lecture was so complete. So a lot of questions were answered. There's a comment from Dr. Fadil for Dr. Walid, mentioning that 50 cases that you mentioned in a year is a very impressive number. Any plans to publish that? And
this is why I call him Dr. Kawasaki. He's having 50 cases. After 50 years, he will publish it.
Yeah, maybe a local registry will be also a good idea. I mean, you know, how.
Yeah, I think registry is the most important thing, to be honest with you.
No,
The 50 cases, yes, we are writing the paper and soon we will submit it for publication, inshallah.
if you allow me, I would like to thank Professor Surjit Singh, Professor Taneja, Professor Walid, Dr. Kalpana, Dr. Amir, all viewers. Really, we want to continue this till, late evening. I know in India it is 2 o'clock now. Thank you very much once again for joining. This was, I think, one of the best webinars we had on Kawasaki. Thank you very much. I would like to thank the viewers also. Dr. Kalpana, if you have anything to say.
No. Thank you so much. I think it has clarified our understanding. We are better equipped to deal with Kawasaki, but I'm sure the very next case again will be calling Dr. Walid and asking for his opinion. That will never stop.
I'd like to thank Tawfiq and Fadi also. Thank you. And once again, Dr. Suji, thank you very much for giving us this time. Of course, we will invite Dr. Sujit for our ovation talk on our annual conference.
Looking forward to that.
This is a good news for all the viewers. Thank you very much.
Thank you. Thank you.
I would like to thank Professor Sochi on behalf of Dubai Pediatric Club and of the audience worldwide. Our Professor Tanje, special thanks to Dr. Kalpana and Dr. Sohrab and Dr. Tawfiq for the hard work they have been doing for months, to get this very successful conference. And thanks for Fadi, and thanks for our viewers, and have a nice weekend. Thank you so much.
Thank you very much.
Doctor.
Thank you. Thank you. Thank you. Thank you.